conducting this program to other regional hospitals. Thanks.
Good morning to all my dear teachers, colleagues, friends and medical students. First of all, thank you, President, for that wonderful introduction about me. And I would like to thank the Council and especially Dr. Nandana Jayatilaka, my colleague, for giving me this opportunity to speak in front of this distinguished audience. Today, I've selected a topic which is a very common, simple clinical scenario. But due to the improper history taking and inadequate knowledge about identifying this disease, we fall into trouble. So I selected the topic as syncope, the physician's dilemma, because most of the time this diagnosis can be obtained with very good history and basic clinical examination, but we miss the diagnosis and we tend to do a lot of unnecessary investigations, which is cumbersome to the patient and also economically costly for the country as an health wise. Right. So why I selected this topic is what is the clinical importance of selecting this topic? It's a relatively very common presentation to the ED, along with ischemic heart disease and chest pain and trauma. Syncope is one of the most, I would say, among the first 5 common presentation to the ED. So that's the main reason why I selected this topic. And as I mentioned, the second reason is if we don't make the correct diagnosis, again with the basic history and examination, we are going to do a lot of unnecessary investigations, which is costly. And also, why this syncope is important is clinically, with the syncope, if the patient had a significant fall, the consequences of falls like head injury and fractures are very much high. So it's a very common clinical presentation, and cost investigation wise and clinical consequences are very much high. So little bit about the epidemiology. Unlike most of the other diseases, it's almost equal in both genders, but the incidence increases with the age, but the outcome depends on the etiology. So we should have a very clear idea about what is the etiology which is causing this clinical scenario. Then only we can predict the treatment, investigations and the outcome. Right. With that brief introduction, if I take a case scenario, this is an 80-year-old man, presents to the A&E department. History was taken from the medical officer and the consultant, and the history was obtained from the son. So that is a very important thing. Sometimes we can't take the history from the patient. So always we have to listen to the bystanders. Don't shout at them. Don't chase them out. Listen to them carefully. And the son says the father is presented to the A&E department for the 4th time without any proper diagnosis during the last 3 times. And this is the 4th episode of fall within last 1 month. When we went further and discussed with the son and the patient, especially here the patient said he felt dizzy with mild blurring of vision preceding the fall. So he has felt dizzy with some sort of blurring of vision, and he says these things happens while standing in the kitchen or wherever for 5 minutes. So almost all these attacks happens when the patient was standing. And then the son says after patient complaining of some sort of dizziness and blurring of vision, the son saw the father falling forwards and he lost consciousness for several seconds. It's not in minutes, but most of these episodes are less than 1 minute. But then things became a bit complicated. Son says he noticed some jerky movements, and also during one episode they have noticed urinary incontinence, but there were no tongue bite. So basically, patient while standing, he has got 4 episodes, felt dizzy, blurring of vision, sudden fall forwards, jerky movements were noted, urinary incontinence was there, but no tongue bite. Then son says when the father lost his consciousness, he seemed to appear pale, and he touched his extremities and they were cold. But then within 1 minute, the recovery is smooth. Patient spontaneously improved with no apparent limb weakness, any numbness or amnesia. So very simple history. How long will it take to take this history? 1 minute. Patient apparently well, standing, dizziness, blurring of vision, sudden fall forwards, jerky movements with some urinary incontinence. He appeared pale with cold extremities, and then he recovers completely without any weakness, numbness, or when you were assessing the higher function, there were no memory impairment and all the higher functions were normal. Right. So with this brief clinical scenario, which is a very common thing, what are the 2 common differential diagnoses? We have to figure out whether this is a syncope or seizure. Why seizure? Because they say there were some jerky movements, urinary incontinence, sudden fall. This could be a seizure as well. Or whether this is syncope. So how are we going to differentiate? Right. Here, if you look further into the detail into the history, here the syncope is more likely than an episode of seizure. Why? Then we should know what is syncope. So whenever we are doing the ward round, commonly in medical wards, ETU, wherever, what is written in the BST is faintishness, dizziness, blackout, vertigo. All these terminologies are very much confusing. So vertigo we know, it's a spinning sensation. Whereas to say that this is a syncope, you should know what is the definition of syncope. So what is syncope? It is a very sudden temporary loss of consciousness. It's not the mere presence of dizziness or blackout. Siya kalpanawa nathi unada. So if the family says patient lost consciousness for some time, that is syncope. So sudden temporary loss of consciousness due to temporary reduction of the blood supply of the brain is syncope. So it should be a very brief event, acute event, but it's only a short time. So it's a sudden consciousness, and the other most important part is the patient will not be able to maintain the postural tone. So he will fall. So while the patient is sitting or standing, briefly they collapse, they lose consciousness, and they are unable to maintain their postural tone. So simple thing, ekaparatama කලාන්තේ හැදිලා වැටුණා, සිය කල්පනාව නැති වුණා, ඒ වෙලාවේදී සුදු මැලි වෙලා හිටියා, ටික වෙලාවකින් සම්පූර්ණයෙන්ම සිය කල්පනාව ආවේ syncope. And it's a very immediate spontaneous recovery. So if it's a seizure, you won't see an immediate spontaneous recovery because seizure is more prolonged and they won't recover immediately. And most of the time it will take some time, and post event also they will appear drowsy, amnesia will be there, some sort of neurological impairment will be there. But whereas in syncope, it's a very immediate spontaneous recovery. And the other part, this recovery doesn't depend on what you are doing. For hypoglycemia, you give dextrose. Some other cardiac event, you give some cardioversion or something like that. But in syncope, it's a complete recovery without doing anything. So patient standing in the queue, sudden collapse, and then they recover. When blood is withdrawn because of the pain, they collapse and they withdraw. So these kind of scenarios are the definition of syncope. Very brief, sudden loss of consciousness with patient appearing pale and complete immediate recovery without intervention. That is syncope. And then little bit about pre-syncope. So syncope is the worst part. Pre-syncope is without losing consciousness, patient will feel lightheadedness. So patient will say, "Mata podi oluwata amuttak danuna," but if we don't do anything, he will go into syncope. So that what it means is, if we don't take the adequate measures like sitting or changing posture, he will go into syncope. So pre-syncope also very important. Today morning also we got 2 patients. Patient will say, "Kalante හැදෙන්න වගේ ගියා වාඩි වුණ ඉඳ හරි නිදාගත්ත හින්දා හරි කලන්තේ නැති වුණා." So that is pre-syncope. Right. So this slide self-explanatory. So when you are differentiating both scenarios, you can see seizure is so lot of things are here. You can get the slides, but the most important thing is the duration, the second bit. Seizures, the duration are in minutes, whereas syncope, it's only seconds, maximum 30 seconds length. So it's a very brief event, but don't think just because patient had a jerky movement or urinary incontinence or tongue bite, that is always seizure, because lateral tongue bite is seizure, but other tongue bites and urinary incontinence and jerky movement can be due to syncope. So the most important things are in syncope diagnosis is the sudden brief event with complete immediate recovery without anything, and the duration. That is the most important thing. So it's again tells the same thing. Any book you can read the differentiation. Don't write, it's there in the books. Differentiation between seizure and syncope. Right. But as clinicians, especially in the emergency department unit and medical wards, everything is not syncope. So you should use your lateral thinking, the history taking ability and basic examination, and you should be able to differentiate with the history whether it's an epilepsy. So I told you epilepsy, the duration is more, they will have a neurological symptom and the duration is more and their recovery is kind of very unpleasant. They will have amnesia, weakness, numbness. Or it could be hypoglycemia. So somebody coming with reduced level of consciousness, always exclude hypoglycemia. Or it could be hypoxia. It could be hyperventilation with some sort of hyperventilation syndrome and hypocapnia. But then always remember this posterior circulation stroke also can present like this vertebrobacillar TIA. And you know there is a condition called cataplexy where patient stands, suddenly lose the muscle tone and they fall. But in cataplexy they don't lose their consciousness. And it could be functional, which is very difficult to differentiate from proper syncope, because most of these people with depression and anxiety also, they come with functional elements. So you should have a situational awareness and lateral thinking ability to differentiate all these conditions: epilepsy, hypoglycemia, hypoxia, hyperventilation and functional component as well. Right. So bit of an overcrowded slide, but I think this is one of the most important slides. What are the causes of syncope? So I told you syncope is reduced blood supply to the brain, which is a transient one. So what are the instances you get this? There is an entity called neuroendocrine, which constitutes 60% of the syncope. I will come to detail about each of these conditions, which is called vasovagal syncope or neurocardiogenic syncope. I will explain in my next slides. Or you can get carotid sinus syndrome, and then yeah, those are the main things. And then you get some sort of situational conditions like cough syncope. Patient will come and say, "I had a prolonged heavy cough and I fainted." Or it could be micturition syncope. Male patients coming in the night while standing and micturating, I got the syncope. So all these are neuroendocrine things mediated via the endocrine and neuronal pathway, vasovagal, carotid sinus syndrome, and these situational things like cough, defecation and micturition syncope. That is the most common thing. And then comes the orthostatic causes. Something like orthostatic means two things. With the posture, pressure can drop, which is orthostatic hypotension, which you get with most of the medications, and also autonomic failure due to diabetes and other conditions. Or it could be due to orthostatic tachycardia, which is called positional orthostatic tachycardic syndrome. Bit of a complicated terms, but I will explain to you what happens in those conditions. Orthostatic, that means with the posture. But comparatively, this bit is very important. Why? Because cardiac arrhythmias can cause this syncope. So when we are taking the history and examination, never miss the cardiac component. So bradyarrhythmias and tachyarrhythmias can cause syncope, and also structural heart diseases like hypertrophic obstructive cardiomyopathy and aortic stenosis, which is very common scenario in elderly people coming with syncope. They can come with syncope. So in summary, when you are taking the history, you should have an idea whether it's a vasovagal, whether it's a carotid sinus, or whether it's a situational, posture related tachycardia or hypotension, or something to do with the heart, right? So these two slides are very crowded, but basically what you have to understand is in all the syncopes, ultimately the medullary vasodepressor region gets stimulated. So you know medulla in the brainstem, the vasodepressor region gets stimulated. So what happens in vasodepressor? You get a bradycardia and fall in blood pressure both. So bradycardia due to vagal tone and reduced blood pressure, both contributing to reduced blood supply to the heart. So don't get confused. Ultimate mechanism is medullary vasodepressor zone stimulation and bradycardia and hypotension. So as I told you, with this simple classification, in syncope diagnosis, it's not the CT brain or Holt or whatever. History is the most important aspect, and the bystander input is the most important thing. So even when we are busy in the ETU, we chase out the bystanders, but in syncope, don't chase them out because we need their input to make the proper diagnosis. And then with the history, careful examination is very important, where you have to assess the general level of consciousness, the higher functions, and system-wise cardiovascular and neurology examination is very important to see what is the pulse rate, what is the rhythm, what is the blood pressure, whether there are any murmurs, and a proper neurological assessment. And also blood pressure and pulse measure while the patient is sitting and also standing. Right. And then investigation, even though I have written so many investigations here, I think in the simpler form of diagnosis of syncope of any sort, history, examination and ECG are the most important things. All Holter, echocardiogram, serum electrolyte, full blood count, TSH, cranial imaging, we can minimize using these sophisticated investigations by making a proper clinical diagnosis with history, examination and ECG. Right. So this is a very famous thing for us during the last 2 weeks. Like when somebody gets an unexplainable syncope, I'm not talking about cardiac syncope. If it's a cardiac syncope, we don't have to go for this test because we know the answer. If there is aortic stenosis murmur, that is causing the syncope. Arrhythmias, bradycardia, tachycardia, we know the answer. But if you get an unexplainable syncope, where there are recurrent falls, where your cardiovascular system examination is normal, where your ECG is normal, and cardiac syncope is safely excluded, then we have to think about tilt table test. So you would have seen in the ticket TTT or tilt table test. Cardio electrophysiology team does it, but for your information, what happens in tilt table test is the patient is left flat for some time and you get secured with tight protection, and your blood pressure and pulse is recorded. And then gradually your inclination is elevated to a level of 70 degrees and you are kept in that position to see the pulse difference, blood pressure difference, and development of symptoms. The symptoms of pre-syncope and syncope, whether you are developing dizziness, blackout, whether you are losing consciousness, what's happening to your pulse, what's happening to your blood pressure, right? So you should have a clear idea, clear-cut cardiac syncope, epilepsy, cataplexy, hypoglycemia. You don't do tilt table test. The unexplainable syncope is where the patient is getting recurrent falls without an explanation, where you have completely excluded the cardiac syncope. You have to think about doing the tilt table test. And what is observed in tilt table test is your basic blood pressure and pulse while you are lying flat, and then the patient is kept at 70 degrees, and then the pulse and blood pressure are recorded, and also the development of symptoms. So these indications, what are the conditions you go for tilt table test? Basically it's overcrowded slide, but you can read, you can go through the online like this thing. So basically differentiating orthostatic hypotension, vasovagal syncope, and there is a condition called POTS. So the last bit is important. These are the conditions where you do the tilt table test to differentiate the orthostatic hypotension. That is self-explanatory, where with the posture the blood pressure goes down. In reflex syncope, that is the vasovagal syncope, both the blood pressure and the pulse goes down. Whereas in the positional orthostatic tachycardia syndrome, when the patient is kept erect, the pulse rate goes up without change in the blood pressure. So simple. Orthostatic hypotension, blood pressure goes down. Reflex syncope, both goes down. Positional orthostatic tachycardic syndrome, the pulse rate goes up with the development of the symptoms. It's not only the mild changes in the parameters, patient develops kind of a pre-syncope, and also they can go into syncope. So same thing, you keep the patient in 70 degree and look for symptoms of nausea, sweating, lightheadedness, irregular heartbeats, and then the interpretation simple. If there are changes, it's positive. If there are no symptoms or heart rate or blood pressure changes, it's negative, right? So even though this overcrowd, try to understand this simple. In type 1 response, you get both blood pressure and heart rate drop, which is the reflex syncope. In the cardio-inhibitory one, you get only the heart rate reduction, and vasodepressor, you get the blood pressure lowering. So don't worry about all these terminologies. Basically, you are looking for fall in blood pressure, fall in heart rate, whether they are occurring in isolation or whether they are occurring in combination, and whether there is a tachycardic syndrome, which is positional orthostatic tachycardic syndrome, because with all these changes, patient will develop syncope. That's our worry, right? So same thing. So little bit of, I was talking about this positional tachycardic syndrome. With the posture, the heart rate goes up. That is the take-home message, and causing symptoms, right? So little bit about orthostatic hypotension. What is the orthostatic hypotension definition? When the patient is kept for 3 minutes in a erect position, systolic blood pressure drops by 20 or more, and diastolic blood pressure drops by more than 10. That is orthostatic hypotension. Understood? So the pressure drops to this degree in orthostatic hypotension. We can reproduce this with the tilt table test. Whereas in positional orthostatic tachycardic syndrome, with the erect position, the heart rate increases by more than 40, or the total heart rate rises about 130. Increment by 40 or rate more than 130. So simple terms, we know the causes of orthostatic hypotension: hypovolemia, it could be adrenal gland dysfunction, autonomic neuropathy, and medications like antihypertensives and diuretics. So orthostatic hypotension, we have to correct the hypovolemia, look into the aspects of managing the autonomic neuropathy, go through in detail about the medications which can cause postural hypotension like thiazide diuretics, any diuretics for that means, AC inhibitors, prazosin, medications like that. And then you try to eliminate the causative factor and patient will be all right. So that's what I'm telling. It's a very simple history and examination. Go through the old records of the medications. Then you can get rid of the syncope. Right. So I told you all these vasovagal syncopes like the neurocardiogenic syncope. If the patient develops a syncope and positive with the tilt table test, what are the treatment options? So I think you would have got confused with all these terminologies. What is neurocardiogenic syncope is, if you exclude orthostatic hypotension and if you exclude cardiac syncope, the other syncopes which happens with emotion, standing for a long time, with the feeling of pain, then that is vasovagal syncope. In these kind of patients and unexplainable syncopes, the most important thing is you have to ask the patient to take the fluid intake about 2 to 2.5 liters per day. So simple thing, advise the patient to take more fluids. Second bit is very important. In our clinical setup, whenever we treat somebody with hypertension, even without our advice, most of the Sri Lankan population, especially the elders, they don't put any salt to their diet. So please tell them to take salt in normal amounts, because 6 grams of salt per day is not going to increase your pressure by any means. So while the patient takes hydrochlorothiazide and AC inhibitors, they cut down on the salt also. Then they develop hyponatremia and syncope. So advise the patient to take adequate salt. And then there is something called physical maneuvers, where what you ask the patient to do something like this. When they are standing for a long time, ask them to clench and do like this. So something like, it's called isometric muscle contraction. And then if these simple measures doesn't resolve the problem of vasovagal syncope, there are certain medications. Unfortunately, the alpha blocker midodrine is not available in Sri Lanka. So simple measure is fludrocortisone, the mineralocorticoid. So that is the treatment. So neurocardiogenic syncope, where cardiac syncopes and orthostatic hypotension excluded, these are the treatment measures. So little bit for the medical students important. Isometric contraction is recommended, the second one, where without shortening the muscles, you do the exercise. Same thing, the tilt training protocols. Quickly, little bit about the carotid sinus syncope. When you wear a tight collar and when you turn the neck very quickly, because of the carotid sinus hypersensitivity also, you can get syncope. But unlike the other syncopes, this is very common in elderly males, and especially when they wear tight collars like me, tight collar with tie, and then any previous history of neck surgery or radiation, they can get this carotid sinus syncope. But this carotid sinus syncope is more provocated by the concurrent occurrence of atherosclerosis, coronary artery disease, use of digoxin and beta blockers. But this bit is important. The sinus node dysfunction and AV conduction abnormalities, because most of the elderly people, they have these conduction defects. So elderly male with conduction defects are more prone to get carotid sinus syndrome with syncope. So what is the treatment? Pacemaker. So for neurocardiogenic syncope, you don't put pacemaker, but carotid sinus syndrome, where you get a history where patient will say, when I was wearing a tight collar, shaving, rotating the neck, I get the syncope. Then you do the ECG and look for any conduction defects, and pacemaker is the main mode of treatment. But apart from that, you can omit the medication. Sometimes fludrocortisone plays a part. Right. Quickly, little bit about the micturition syncope. It happens in men because we stand and micturate. So when we stand and micturate, especially in the night, most of the elderly people comes with micturition. Mudra karnakote ekapata kalanti hadile batuna. And they end up with CT brain without proper history, and they will say within 1 minute I recovered, but CT brain is done in the night. So this is micturition syncope. Why? One thing is, after lying down, when we get up, there is a postural drop anyhow. So that is one reason. Number two, while standing and straining, due to the Valsalva maneuver, bradycardia will happen. And because of the emptying of the bladder, there is reflex vasodilatation and hypotension. So micturition syncope, so many theories are there. Men standing nighttime micturition, they develop the syncope because of the posture effect, straining and rapid emptying of bladder. So what are we going to do? Simple measure is, ask them to get up from the bed, sit for a while, just do some exercise to the legs, and after 3 to 5 minutes ask them to walk to the toilet, sit in the commode and micturate. Because most of the time when they sit and micturate, the postural drop will not be that much. Or else you can ask the patient to use a urinal. So it's a very simple thing rather than going for Holter monitoring, CT brain and lot of things. So, and then other thing is, avoid excessive alcohol, because if you take a lot of beer in the night especially, you tend to micturate, and because of the alcohol you will develop anyhow hypotension, and alcohol will precipitate this micturition syncope. And don't get out of the bed suddenly and urinate sitting down. Right. I'm coming to the last bit of my lecture. So before coming to cardiac syncope, the take-home messages are: syncope is a very transient, brief event with complete recovery. Most important things are history and examination. Most of the syncopes are vasovagal or neurocardiogenic. So with correct diagnosis, we can minimize the list of investigations, and we know when to do the tilt table test and what are the simple measures and medications used. And we talked a little bit about the carotid sinus syncope, where it is associated with conduction abnormalities, so most of them will need pacemaker. And micturition syncope can be managed with very simple advice. So last bit of discussion will be about the few cases of cardiac conditions which cause cardiac syncope, because out of all the lot, this is very important. So why these are more dangerous? We need a correct diagnosis for proper treatment. Right. So if we take the ECG, this is a 75-year-old gentleman coming to the ETU with an episode of syncope. So what is there? There is a prolonged pause, no? So there is a pause and kind of asystole. So this is sick sinus syndrome, because you get normal rhythms and then you get a long pause and then the normal rhythm comes back. So don't say this is vasovagal syncope or micturition syncope, because the ECG shows a defect where there is a long pause. So this is called sick sinus syndrome. So what is sick sinus syndrome? You know, our SA node is the intrinsic pacemaker in our heart. Due to the degeneration and fibrosis of the intrinsic pacemaker, which is the SA node, the conduction system slows down and you get a bradycardia. But in sick sinus syndrome, it's not only bradycardia. With that, you can get arrhythmia and also bradytachy syndrome. So concurrent occurrence of bradytachycardia, arrhythmia and sinus pauses all can lead to syncope. So you can get all these, right? So what is the reason? It's mainly the age-related degeneration, just like cataract development. The SA node also ceases function with age. So it's the degeneration of fibrosis of the SA node. But these things are precipitated more with the ischemic heart disease and medications like beta blockers, quinidine and digoxin. So what is the treatment? Sick sinus syndrome, you can't give fludrocortisone, increase oral intake and salt and weight. This management is totally different. You have to refer to the cardio electrophysiologist for pacemaker, and because they are prone to develop arrhythmias and tachyarrhythmias, rate controlling drugs should be given. Then you get another ECG. All PG train is very important. Long QT interval, where because of this QT interval prolongation, you tend to get arrhythmias and syncope. So whenever you look at the ECG, try to learn about long QT syndrome. Causes are so many, but you should remember when somebody is having a prolonged QT syndrome, you have to avoid common antibiotics like azithromycin, clarithromycin and ciprofloxacin, and also antidepressants, antipsychiatric medicines, and these anti-arrhythmic drugs should be stopped. So long QT syndrome, be careful with your medicine usage. Right. So in long QT syndrome, if you correct the causative factor, the long QT syndrome will disappear and syncope will cease. Then common, not common, but young people getting sudden cardiac deaths, arrhythmias and syncope is HOCA, hypertrophic obstructive cardiomyopathy, where you get this dagger-like Q waves. So HOCA, whenever you are taking a history of syncope, mostly in a young person, ask about sudden cardiac death, any preceding palpitation, chest pain, SOB. But about the exertional, most of these people come with exertional syncope. So again, history, examination, look for murmurs, evidence of left ventricular hypertrophy, check the blood pressure. So HOCM is a condition where you get features of left ventricular hypertrophy, Q waves which are dagger-like, and also septal hypertrophy features. So you have to be careful in this condition, autosomal dominant condition. You get a systolic murmur, mostly in young patients. So HOCM you don't see in elderly people. Young patient coming with syncope, you have to be careful. So get a proper history, do the examination. And what is the treatment for HOCM? Implantable cardioverter defibrillators, ICD. Then Brugada, which is again a channelopathy. Go home and read about ECGs, can't teach everything, but there is a condition called Brugada. Again, you take the history and examination, family history, sudden cardiac death, arrhythmias, syncope, think about Brugada. And again, the treatment is ICD. This is a very interesting clinical situation. Recently, a 22-year-old young boy from a hospital in northwestern province was transferred here for cardio-electrophysiologist's opinion. This young boy had gone with a syncopal episode. History was taken and presumed to be a seizure, and they have done the neurology referral, CT brain, electrolytes, TSH, everything was normal, but the ECG showed WPW syndrome. So it was a syncope. So history, they clearly says sudden loss of consciousness and quick recovery. So it's not a seizure. So WPW syndrome, why this happens? You know this SA node, AV node, Purkinje fibers, there is an accessory pathway. So the accessory pathway gets activated and you get arrhythmias. So you have to be careful in somebody coming with tachycardia and WPW syndrome, don't give beta blockers, calcium channel blockers, adenosine and digoxin, because all those medications will stop the normal pathway and activate the accessory pathway, and arrhythmia will provocate. So be careful with your medication usage in WPW syndrome. These are the ECG changes. You get a short PR interval with delta wave. So if you do the ECG and pay particular attention, you can diagnose this. So what is the treatment? Radio frequency catheter ablation. But my last slide, elderly people coming with syncope, never forget aortic stenosis, which is one of the common cardiological causes of syncope in elderly people. So ladies and gentlemen, in summary, I touched upon a very common, simple, but complicated, I would say, can't say simple, clinical diagnosis of syncope, where if we don't take a proper history and examination, we will miss the bus and we will do a lot of investigations and will not manage the patient properly. So you should know what is syncope, how to differentiate a syncopal episode from seizure by history and examination, and get some idea about what are the types of syncope, where cardiogenic syncopes are the most dangerous one. So common ECGs which causes cardiac syncope, you should have a good idea and what to do, when to refer to the cardioelectrophysiologist. And then on the other side, micturition syncope, simple diagnosis with history and advice. And then carotid sinus syncope, you have to think about concurrent SA node and AV dysfunction and using pacemakers. Whereas in vasovagal syncope and unexplainable syncopes, you go for the tilt table test. You should know when to do and when not to do and how to interpret. And then all these neurocardiogenic syncopes, you have to advise the patient to take more oral intake, increase the salt intake. Some medications like midodrine and fludrocortisone and beta blockers can be used. Thank you very much.